Unfortunately, most people who are doing hormone replacement therapy don't really understand that hormones involve every single system of the body. So when I started doing this, some of you may be my patients from that era, 1994 to 1996. I investigated exactly what's going on with deficiencies of hormones. And at that time, most of the people were talking about menopause, premenopause, postmenopause, and it had no meaning. So I had to redefine terms. And what I tried to do is establish a language that makes sense. So what I learned is that really hormones, replacement of someone's deficient hormones, the same as insulin is to diabetes, which means that you don't go through diabetes, you don't end diabetes. What you do is you replace insulin if you're deficient in insulin. So the model for diabetic therapy was what I utilized for hormone replacement therapy in women. So we still hear the words menopause. However, it really has no clinical meaning. What the basis of what I do is to establish criteria such that we can now clinically measure exactly down to the nanogram of how much hormone is circulating in someone. And that could be utilized to be replaced so that we have a level that is consistent with someone, let's say 38 to 42. So we can do the same thing for men in our TRT section, where we try to evaluate what it is that's deficient, especially testosterone. But getting back to the female side, we have discovered that it's not just to replace someone with one hormone. At that point in the 90s, everyone was talking about estrogen being the hormone of menopause. And in fact, that was untrue. That was a pharmaceutical marketing scam. And unfortunately, the result was an increased risk of breast cancer. Now, estrogen-based therapy or unopposed estrogen does not cause breast cancer, but it stimulates an existing breast cancer. Progesterone-based therapy, which is really the hormone of pregnancy, does inhibit the growth of most cancers that are produced in a woman. If you study the urine of patients, of women who are between 35 and 50, almost 100% of women have the broken down particles of the nucleus of breast cancer cells. And what they do is that the target cells, the immune system, recognizes that and then goes in and attacks the cells and splits them up and breaks them into little particles. So it's fair to say that breast cancer is not a breast disease, it's an immunological disease. And you can say that pretty much about all cancers. In fact, today, 30 years later, the basis of chemotherapy is now transferring to immunotherapy, because we now recognize that the basis of most cancers are immunological deficits in our body and an excessive amount of toxins or free radicals that we have been exposed to either as a child, teenager, or as an adult. So once I began to examine my patients that had breast cancer, the most common theme that I found was that they were on, at that time, Premarin. For those of you who don't know, Premarin stands for pregnant mare urine, which is the hormone is a estrogen compilation that is extracted from the horse's urine. Strange as that is, that was the common therapy. No studies were ever done by Erst, which was the pharmacy company that had developed that, to ever show whether or not indeed it increased or did not increase breast cancer. It was grandfathered in by the FDA with no research whatsoever. And the unfortunate part was that that was considered standard operating procedure for OBGYNs treating women who have symptoms of hot flashes, et cetera. Nobody even began to think about progesterone-based therapy until I guess I was one of the first ones to really evaluate the value of progesterone. Those of you who were pregnant could know that during pregnancy, various changes occur that are very positive. One is that your hair grows better, your face fills out with collagen, your bones get thicker, your muscles increase, your sex drive increases. So progesterone, the hormone of pregnancy, I knew is an excellent hormone for women. That being said, the value of testosterone also was important. Testosterone is derived from progesterone. So progesterone in your body is transformed into testosterone enough for women. The problem with certain modalities of treatment is that they're purely testosterone. I had a patient today whose testosterone level was male levels of testosterone due to the implant. And the implant does give a lot of testosterone, but that's really an end product. What you really want for your bones, breast health, and all the other symptomatology is to have a balanced therapy, which progesterone provides, with a little bit of estrogen and a little bit of testosterone. So you may ask, why am I using estrogen at all? I just said the bad things about estrogen, but I really said the bad things about unopposed estrogen. In my experience, if you don't give some estrogen into the therapy protocol, a woman will complain of dry eye, dry vagina, and dry skin. That is a side effect of progesterone. So we do give a little estrogen, just enough to prevent those symptoms to become problematic. What I discovered in my research in the 90s was that the adrenal gland is very important in sex hormone management. So DHEA, which represents the adrenal gland, I began to measure and began to treat with supplementation included into the therapy program. A deficiency of DHEA causes lack of energy, sleep disorders, and general loss of energy. So what I tried to do is give a balanced program. I added on the adrenal gland supplement that was called DHEA, which stands for dihydroepiandrosterone. So when you put it all together, the way that therapy should be looked upon is that you're replacing hormones that have been deficient for whatever reason. Now, what I try to develop is what levels does a woman's blood have of each of the hormones, dependent on how much I give her. That kind of equation was unknown at the time. No one knew if you give X hormone, you get Y level. So I remember hundreds of patients volunteered to get tested all the time. I used to give this level and I checked that level. And I found that, interestingly enough, there was a lot of individual variation, but there was a standard deviation, meaning that more or less you can get a bell curve established such that you can pretty much predict what levels a woman will have based on her body mass, based on her age, based on her severity of symptoms. And it seemed to have worked over time pretty well. So we're pretty much right, I'd say about 95% of the time. Sometimes you need to tweak. There's individuality effects that occur. Believe it or not, someone who moves, someone who has a lot of stress, someone who changes sexual partners, all of these, believe it or not, affect a woman's hormone levels and her needs and symptoms. So I think on the female side, that pretty much covers it. On the male side, unfortunately, the myth that you need a lot of testosterone to replace a man's sex drive is not true. Men do have deficiency of testosterone that can be easily replaced. Unfortunately, I found that the best way to replace it is with injection form. The creams, the gels don't work. They don't give a consistent level. And one of the things we do best is that we don't give too much. We don't want to make Arnold Schwarzeneggers out of all our patients. So we try to give, just again, replacement to where they would feel better, sleep better, lose their joint stiffness, become more sexually active and feel more confident about themselves, and also fat redistribution. So what happens with most men in their 50s and 60s? We all know. We all gain midsection fat. That is due to the fact that not only are we deficient in testosterone, but we have a surplus of estrogen. So I began to check all the men for estradiol levels. And lo and behold, almost all men we saw for testosterone deficiency type symptoms had an excessive amount of estradiol. Estradiol is the hormone of the female hormone, and it does cause distribution of fat in the midsection. So not only does that increase heart disease, it also doesn't make a man feel good about his body. So we began to treat with anti-estrogens almost routinely on almost every man who presents himself with low T with estrogen, anti-estrogen to basically take care of that problem. We're very successful. So we don't need to just focus on testosterone in men. We also need to focus on estrogens. I think that's pretty much a good introduction. So what we have here is we've taken questions that were given to us before from the internet, and I'm just going to read the question and then answer it. And if you take notes or you have any other questions, then I guess we're going to open it up to all of you people that want to ask the question. So first question was, can I start BHRT if I'm still having a period or I'm in perimenopause? So let's talk about the word perimenopause. I have no idea what that means. I use the words that you're clinical deficient in one of the 4 hormone groups. Now, I understand we use the word perimenopause to describe that period of time that women are going through hormonal changes, but to me, it's not very useful. But answer to the question is that it depends on your levels. If you're still getting your period, we can still be hormone deficient. Most women go through a period of time before they stop having periods where they're not producing adequate progesterone. So if you don't call that perimenopause, that's fine. We check it. We check it usually day 19 to 21, and we see what the progesterone level is and replace it accordingly. That also is dependent on a woman's cycle. So we do depend on quantifying what it is that the patient is deficient in. Next question. Are hot flashes or any other symptoms of hormone deficiency bad for your health? Well, what I try to do is to establish therapeutic levels of hormones to do medical benefits, not just cosmetics. So hot flashes, night sweats are all due to stimulation of the vasomotor center in your brain with LH surges. LH surging occurs when you do not have the ability to produce enough hormones, so your body is trying to produce the hormones by a central nervous system mechanism from what we call LH surges. LH stands for luteinizing hormone, in case you want to look it up. So when you have that symptom of vasomotor instability, it really is not going to hurt you. It has no real benefit, but it indicates that your body is trying to stimulate your body to produce the right proper amount of sex hormones. So we use that as an indicator only that gets people in, but we tell them that there are other things going on that are more important medically. What's going on? Your increased risk of breast cancer from lack of progesterone, your increased risk of uterine cancer for lack of progesterone, your increased risk of bone loss and osteoporosis, osteopenia. Now, if you replace the hormones properly, this goes away because you're giving the hormones that you need to prevent the bone loss to continue. So it's a good indicator, but in itself is not dangerous at all. So is there a benefit of starting BHRT sooner than later? Well, I think most women come to me with either the diagnosis of osteoporosis or they have a diagnosis of severe mood changes, insomnia, vasomotor instability, low sex drive, inability to have intercourse secondary to vaginal dryness. All of these things bring the patient in, but it really doesn't matter what the symptom is because it's very individual. What really matters is how do we evaluate the hormones specifically with blood testing in the right proper time in the cycle, and how do we replace that so that it basically gets treated from the cause, not treating just the symptoms. We have a list of 14 symptoms on our website that people fill out, and the average is about 9 to 10 different symptoms that people have. So it's not just 1 or 2 symptoms. Usually it's quite a lot, actually. How does removing ovaries surgically affect your hormones? I just had a patient this week. She was 42. She had a hysterectomy with a bilateral salpingophrectomy, and when she was 35, she had 7 years of hormone deficiencies. The doctor never even suggested to her to take hormones. She was a mess. I mean, she couldn't have intercourse. She couldn't sleep. She was affected in such a way that she lost her job. She hardly had a intimate relationship with her husband. So again, surgical menopause is a serious stoppage of all sex hormones at one particular time. And the fact that she received no placement at all, well, no replacement at all, to me was very bad. And she was a mess. And she was told by her doctor that she needs to see a psychiatrist because obviously there's something psychological. So let's refer to that one statement. When in 1940s, when diabetes was rampant, but they had no insulin, and during World War II, these patients were hospitalized for diabetic encephalopathy. Very fascinating articles were written at the time when insulin became available after World War II, when they started checking blood sugars. And 30% of all hospital inpatient for psychiatric illnesses found to be diabetics were given insulin and released. So I find it really fascinating that 100 years later, or 80 years later, we have the same situation, that women are treated psychologically when indeed they have a physical deficit, which means sex hormone deficiency, similar to the diabetics in the 1940s that were deficient in insulin. It's amazing how medicine as an institution did not learn from that and understand that women are not crazy when they're having symptoms. They know their bodies. It's crazy to say to them that they're crazy instead of finding out what it is that's being deficient, in this case, sex hormones. Are there home remedies that will treat hot flashes and other symptoms of hormone deficiency? Yes. So you see advertising on TV all the time for estrogen-based therapies that are plant-derived, as if plant-derived somehow makes it fine. They come from black cohosh, vitex, various other herbs that have estrone. Estrone is a very dangerous estrogen. That is the estrogen that causes breast cancer. So when you see people coming in, they said, well, I took this substance, that substance, and my hot flashes are gone. However, I have A, B, C, D symptoms. I say, who told you to take it? Well, I saw an article in women's magazines. I saw something on TV, and that's not good because the information is dangerous. It is definitely a risk factor when you take unopposed estrogen, just like it was with Premarin, even though it's quote plant-derived versus animal-derived. To me, that makes no difference. The body sees estrone as estrone, and unfortunately, it does stimulate existing breast cancer. All right, so now we go to the second phase of questions, which is about bioidentical hormone replacement therapy. We'll call it BHRT for short. So what are bioidentical hormones made of? Okay, so it goes to the question of natural versus synthetic. I don't care if something is natural, doesn't make it good. Cyanide, arsenic is natural, but it can kill you. So let's not lose the word natural as the highest level of security. What I like to say is bioidentical hormones supply you with the exact hormone that you have produced in your ovaries since you were 10, 11, 12. And that to me is most important. So the body is used to it, doesn't consider it an antigen, does not consider it a toxin, does not consider it a poison. When you have synthesized products that are not bioidentical, the body will react to that and consider it an attack on some level, and it causes an inflammatory response. And time again, I've seen people put on synthetic-based HRT, whether it be the patch, whether it be some kind of other form, and they have a terrible reaction. That is an immunological reaction to a toxin. It's like giving someone a poison. I see a lot of that with cholesterol-lowering medications. People have tremendous reactions to them, and they keep on taking them because their doctor says otherwise they're going to get a heart attack and die, which is just not true. There are a lot of natural products, in that case, I'll use the word natural, that come from Italian grapefruit, that come from garlic, that really does stabilize and improve cholesterol with no defects because they're just recognized as a food source and have a tremendous beneficial effect. So I like to use the word bioidentical versus natural, but the products that we use are not only all FDA approved and supervised, they have to be. Anything put into someone's mouth has to be done. Remember, it's the Food and Drug Administration. We are very careful to use compounding pharmacies that use the best product, that have tremendous amount of supervision and surveillance to make sure that we get what we order. That to me is the most important. So many compounding pharmacies do crappy jobs as far as consistency. And I have partnered up with two of them that are the best I've ever dealt with. They are consistent, they're diligent, and that to me makes more difference than whether or not something is natural or synthetic in this case. They all come from, by the way, from plant. The progesterone is coming from yam, and the rest of the three come from a soy base, but they don't have the soy protein left anymore. They just extract the hormone from the soy since it's so easy to be extracted. How quickly does BHRT treatment work? So in my experience, there's a gamut of symptoms that take different time frames to get better. Almost right away, the dry vagina, dry skin, dry eyes, hot flashes, vasohormone instability, insomnia get better pretty much within 2 weeks. May not get all better, but they definitely are improved. And the patient feels better. The longest issues usually are sex drive and sexual performance, meaning having orgasms, and the issue of hair loss. That usually takes 3-4 months in the average to really get to where patients are happy. So there is that period of time, of course, variable depending on the person, but it's not all at once, boom, like a drug. You get this drug, you get Y response. Very individual therapies have different time sequences such that when you take the medication, it may take a while to get you better, again, depending on how bad you were to begin with. Let's see. Are there other benefits of BHRT besides relieving symptoms of hormone deficiency? Like I mentioned, when you balance your hormones, your risk of breast cancer, uterine cancer almost go to zero. And when you properly balance your hormones, especially progesterone, testosterone, your muscle mass will increase, which is a big problem, especially today, because most of my patients work out. They say my workout is terrible. I don't get any results. They go on the hormones and their workout starts to produce results. That's number one. And number two is that bone loss is a serious problem as we age. Now, And women who started say, well, I'm not going to, I'm not going to have a bone fracture. Usually that's correct. It usually occurs in your 70s. But I have patients who've been on it for 20, 25 years. They're 75, 80 years old, and they have perfectly normal bones with no bone loss whatsoever. They will never get a hip fracture from osteoporosis. And the longevity of that person will increase on the average of about 7 years. So I think that medically, it's important to get to proper levels so that you can avoid that complication later in life. We all know people in nursing homes that they're 86 pounds and they have no muscle mass to begin with. And these are at risk for all sorts of illnesses if they do get sick. Muscle mass is important to maintain, not just in men, but also in women. And I think that's an important asset when you try to balance someone's hormones, especially utilizing the proper amount of testosterone so that you don't have levels that are androgenizing. Androgenizing means to become like men. My patients do not want to be men. They want to be female in their look, in their bone structure, and they don't want the side effects and complications of excessive testosterone. The pellet is very big now in Florida. It's not big around the country. To me, it has not been properly evaluated. Most doctors are doing it without understanding what happens to the pharmacology, but they really spike with very high levels of testosterone to the levels of male levels, and then they crash, then they come down. And the crashing part of a pellet testosterone therapy is very devastating for a lot of patients. We probably have 400 or 500 patients now that have been on the pellet who come with the exact same story. So we don't do pellet therapy here. We don't believe in it. We think that it is not a long-term management of hormone deficiency. How long is it recommended to stay on BHRT? Well, when patients ask me that, I usually joke and say, just until you're 90. When you're 90 years old, we'll talk about it. Probably not going to be around when they're 90 years old, but there's no reason to stop it. Diabetics do not stop insulin. They keep it going because they need it. So unfortunately, we don't have an administrative system whereby we can make someone produce their own hormones. It just doesn't happen. So what I would say is that there's no reason to stop. Now, we have patients who stop because they just want to stop and they feel like terrible. And they go back on and they'll never stop again. So I don't think it's important to stay on it until the rest of your life, but surely maybe at 90, we'll talk about it and maybe decide maybe it's time that you need to stop it. But in general, we don't have many patients stopping them for long periods of time. So I think we're done with the internet questions. So
there's a full question in the chat.
okay. So the question I received is, if you suffer from rumination or depression, does hormone treatment help? Very good question, actually. So the issues of anxiety, depression is multifocal. So what I tell patients is that you may have a concomitant post-traumatic stress disorder. You may have other psychological issues going on, but definitely if you don't sleep, you don't feel well, you're not intimate with your partner, you will have more symptoms of depression than you are. So I have what's called a what's left syndrome. What left means is that let's get the hormones equalized, let's get that taken care of and see what's left. In my experience, I'd say 90% of people are better. Now, we do have a psychotherapist on staff that will take care of the other 10% who have an underlying anxiety depressive disorder, whether it be from post-traumatic stress disorder or any other psychological illness. Okay.
Okay, that's the only question we got in.
Okay. Do we have any other questions from the audience? Wow, that's pretty good. We have a lot of people here.
I want to make sure that was to Rebecca. Can you make sure we answer that fully? Because that question from because that was the topic. How to treat PCOS.
Well, this is the takeoff of the original question that I just answered, but I think when you look at the balance therapy, you can't really separate out the effects of estrogen, the effects of testosterone, and the effects of progesterone when it has to do with depression, because all three are interrelated as far as conversion from one to the other. So each body is different. which means some people convert progesterone higher to testosterone, and then some people convert testosterone higher to estradiol. So that has to, as I said, that has to be tested. The main hormone to treat depression is going to be progesterone. So those of you who are pregnant may remember the period of time which is called postpartum, right after delivery, where you may have experienced some depression. That depression that you experience that we call postpartum depression is definitely related to the fall of progesterone. So what I did when I was doing OB was I would treat those patients with progesterone therapy and everyone felt better. So I think that we are mistreating or misdiagnosing what we call postpartum depression. So definitely hormones have a play in treating and preventing severe depression. Okay, another question we have is how to treat PCOS. PCOS is a shortened version of polycystic ovarian syndrome. So let's talk about that. It's a very good question. We have a lot of women in their 20s and 30s coming to us for hormone balancing, and most of them have polycystic ovaries. And what the doctors do now is they just give them birth control pills, or they tell them to, there's nothing we can do, and sometimes even they recommend surgery, which is crazy. So what you have to do is, again, consider the etiology. What is the etiology of PCOS? It's multifocal. There is many enzymatic deficiencies in the ovaries that produce the ovaries that present to us as polycystic ovaries. So instead of deciding which enzyme is deficient, we classify it all together. But associated with PCOS, usually weight gain and what we call androgenation. The androgenation is the male effect, which includes acne. Sometimes it includes other symptoms that are severe maleness symptomatology, and it's very unpleasant for the patient. So regardless of the etiology of that, we try to look at this as this. It is mainly a androstenedione surplus from the covering of the ovary that is producing the symptoms. So we have to supply the patient first by cutting off the supply of androstenedione by birth control pills for a short period of time, and then replacing them with cyclic therapy with progesterone, as if we simulate a cycle, and it works very well. We sometimes have to add some testosterone to it, believe it or not, because testosterone then will convert to certain amounts of estrogen and estradiol to create a balanced therapy. So the answer is, how do we treat it? By, again, balancing your hormones properly. And we don't rely on birth control pills for a long period of time, especially women over 35. So I have stopped prescribing birth control pills for women over 35 because of the increased risk of breast cancer. Okay, does the doc treat cholesterol conditions, and what bioidentical substitutes for allopathic, what bioidentical substitutes for allopathic? Okay, so very good question. It is related to what we do. So there's three aspects to what we do, which I found is necessary. First of all is the sex hormone arena, which we discussed at length. Second of all, the supplementation, especially with the immune system, and that includes cholesterol therapy. And the third thing is weight loss. Unfortunately, most of my patients come to me with weight issues, whether it be male or female. And so we have expanded our program such that, especially when patients come in, we do discuss all the issues of weight issues that are very important. We also discuss the issues of cholesterol, because cholesterol is related to the sex hormone deprivation. So we as a group may not know, but the precursor to progesterone is cholesterol. So my experience has been that if you properly treat with progesterone, your cholesterol will drop. Now, the other thing is, why is a cholesterol a problem? Is there a magic number somewhere established that 200 is normal, 201 is abnormal? The answer is no. This is a marketing scam that is developed to sell drugs. So it depends on the ratio of the HDL to LDL, and the LDL, the ratio is just as important or more important than the absolute values. So I try to look at the entire cholesterol profile and also realize that most of the drugs out there that are allopathic, which means prescription drugs, do not have any studies to support reducing heart attack or stroke whatsoever. If you are diabetic and you've had an MI, a heart attack, then there are some studies to support taking the drugs to lower your LDL. There are natural substances out there that we use all the time in this office with excellent results. Italian grapefruit, which is happens to be called cholesterol pure plus, and garlic products that contain non-odorous garlic. These have been working very well for us, very successful. And I don't look so much at the absolute levels of cholesterol as I do looking at the ratios. I am not a fan of checking cholesterol every 3 months or 6 months. To me, it makes no sense. A recent study was done on people over 65 to say that very low cholesterol is actually increased risk of sudden death. So cholesterol in itself is defined as the problem. Atkins did tremendous amount of work with this 50 years ago and showed that no, cholesterol is a resultant of insulin problems, not in itself the problem. So if you straighten out your insulin level, which is usually high, especially if you're pre-diabetic, then your cholesterol will go back to normal. I think it's a great way to approach it. And because insulin is the center core of cholesterol issues, we do focus very much on measuring and understanding your fasting insulin level as it relates to hemoglobin 1AC and as it relates to your fasting blood sugar. So I do look at cholesterol as an insulin problem, not as a cholesterol problem per se. Okay, so what if a patient doesn't have a weight problem but has a high cholesterol? Again, the way I present cholesterol problems to a patient is this. If you're, I don't know where all of you are from, but here in Florida, there is 95. I-95 is a major road, a major highway, 4 lanes, 5 lanes. But let's say driving down 95 and all the lanes are pushed over to the left, the last 2 lanes to the left. And all you see is red lights and you see fire trucks and you see police cars and you see ambulances. If you're driving by and you're from Mars, you're going to say, wow, all these trucks caused this problem. Because what you don't see is that you don't see the accident. So in your blood vessels, especially your coronary blood vessels, by the way, it is the smallest caliber lumen of all your major blood vessels. You don't see what the original injury is. You don't see the accident. The accident is little tiny free radicals will attack the arterioles, the intimate levels inside your blood vessel. That intimate level, it's called the intima actually, is a very susceptible item. And when it becomes a little hole in it because the free radicals attack it, along come your platelets and clog it up. Happens all the time. Then cholesterol comes in and is the final patch. So the final patch is like you have a hole in the wall and you're putting plaster. That's cholesterol. Cholesterol is not the problem. It's what's underneath the cholesterol that caused your initial problem, which is where, for example, antioxidants fight free radicals. CoQ10 has been shown to reduce heart attack and also keep your vessels clean. Why? Because CoQ10, coenzyme Q10, is a free radical. It's excellent at combining with a free radical scavenger. It's excellent combining with the free radicals and not allowing it to cause further damage. So again, CoQ10, cardiologists have written about it for 50 years, and very few cardiologists are using it because that goes half their business. CoQ10 with omega-3, for example, which is an anti-inflammatory, DHA, EPA, all of those in the omega-3 group, are all excellent reducers of inflammation secondary to free radicals that can be easily treated with perfectly safe antioxidant therapy that we utilize in our practice. So I think it's the approach of how you look at things versus how it end result turns out to be. Because we'll never know, whether you're taking antioxidants, what your free radical level is. But we do know that those with heart attacks, especially family history of heart attacks, have much more tortuosity of the vessels than other people. So if you're going to have tortuosity, which means curvature like that, you're going to have a slowing down of your blood flow through that coronary artery, which will then obviously increase your risk of having more damage done to the inside lining, the endothelial lining of the blood vessel. So I think we have to look at this a little differently. Now, if you have a high carbohydrate diet, a high sugar diet, whether it be from fruit, galactose from milk, or whether it just be regular carbs that get broken down into sugars, you're going to have much more inflammatory response to that, especially if you're pre-diabetic. And most of the injury to the body of diabetes, for example, is vascular. So you have to look at the carbohydrate intake, which is considered a poison to most humans, versus the protein that we need to consume to keep us healthy. So you have to, again, expand into the etiology or the cause of the problem and not just treat symptoms with a drug and say, here you are. In fact, there's a lot of studies showing with high blood pressure treatment, for example, is that the drugs actually can do more damage than it helps. So we really need to look closely at what it is that we're doing and try to prevent all the illnesses we mentioned by proper nutrition, which is what we do, by taking supplements, unfortunately, we need because our food supply has been so depleted over the last 50 years. These are good questions, by the way. I like. How long does it take to start getting in a better mood? Well, as soon as you see us, you're going to be in a better mood because you're going to feel that someone is actually beginning to take care of you. We have so many patients who come here that just feel desperate. You know, they'd say, I'll do anything. And that's not good. You don't want to be desperate. You just want to try your best to deal with what it is that we try to help you with. And we do encourage people to research before they come. I want to make sure you understand the why, not the what. But I know you're referring to a better mood from hormone deficiency. Well, as I said, if you have a sexual relationship with someone and you're able to be intimate, in my experience, most women feel better. They're in a better mood. They feel better about themselves. They feel better about their relationship. They feel better about their working relationship. If it's in a business situation, I have many professional women who come to me and say, I can't function at work. I just can't do it anymore. You know, I don't want to be around people. I feel bad about myself. So if you feel better about yourself in general, you'll be in a better mood. But, you know, maybe nothing will get you in a better mood. You know, 5% of the population, no matter what you do, they just hate being alive. You know, you can't change that with hormones, unfortunately. I wish I could. Okay, I'll read this out. My doc says I think HDL is too high. My non-HDL is too high, and that is the main bad thing. What do you think of that? She says ratio does not matter anymore. Well, depends on what non-HDL it is. So if you have a very high, let's say, triglyceride level and a very high LDL, there are things that you can do to lower that. Most of that is nutritionally based. So I think the ratio is still very important. We have had in our hormone patients, we probably have more than 10,000. We have not had one heart attack. So progesterone, it's about not just absolute value of LDL. It is about the fact that statistically proven high levels of HDL, as long as you have a high HDL, it is very protective. So HDL comes from genetics, but also comes from exercise. So that's why we say you exercise, it raises your HDL, and you have less heart disease. That's the reason. So number one. Number two, hormones themselves, especially progesterone, does balance out and lowers your LDL and increases HDL. Especially, believe it or not, some estrogen products also can increase your HDL. So I don't think it's that simple just to say your absolute value of LDL is a direct indicator. I have not seen a study that supports that. If this person, whoever sends that, can have her doctor send to me the study that says that an absolute value of LDL is a predictor of heart disease, I'd like to see that. Okay, so I think we're done for questions. So I hope all of you had some benefit from this. I enjoyed it, and we'll see you soon. Thank you.